This meeting is being recorded.
Okay.
Welcome everyone to the second webinar of this year. And this webinar is focused on voice, speech, and communication in Parkinson's. We're joined by John Dean, one of our wonderful friends and partners. He is a speech and language pathologist specializing in Parkinson's. He has worked with the Parkinson's population for 15 years. And he's going to talk about voice, speech, communication, and the upcoming 10-week virtual class. So at this time, I would like to hand it over to John. And thank you for attending. And thank you so much, John, for presenting today and being such a wonderful friend and partner of Parkinson Foundation, Western Pennsylvania.
Yeah, no, I'm really glad to be here. You guys have had a great organization for a long, long time, and I like to see it just keep chugging along. I always like to say punching above your weight class. It's been really good. I'm going to get into my slides. I'll go through some of that. I'll talk about what was on the table today, including the class that's coming up, and then I'll probably do a little bit of a demo near the end. I think maybe at the beginning, I always like to ask if anyone has some burning questions, because sometimes we get excited and we forget. And so does anybody have anything on their radar that they purposely came here because they want to make sure they understand A, B, and C about speech? All right. And so I'm looking to see if I see anybody talking, but they're muted. Okay, good. Well, then I think I'm going to go ahead and pull the slides up and we'll get started, folks, okay? Just got to get my, I believe it's trying to do this in presenter mode. I don't think I need that. So I'm just going to switch it out of there. Am I going to share my screen? Is that what you want me to do here?
Yes,
Maybe you can spotlight me, or is that what I should do? Or I can't hear you. You're muted.
Okay. Oh, sure. Okay, I have you pinned, but I can remove your pin.
That's okay. Yeah, here we go then. Here, let me just cut that. Good. It's just it's showing a kind of a weird background here. I don't know why.
Okay.
So let me just try this again. I don't know why this is doing that, but I will cut it out.
I changed you to host. Perhaps that will elevate you in your privileges.
Yeah, well, I'm very much about that. Yeah. And then now F5. Should we in the presenter mode? That's strange. There, and it looks like it's a little bit small though. So let me try it here, folks. I'm sorry for this. This is a great little snafu in the beginning, but I'm sure I can figure it out. Let me try it this way, folks. There we go. Oh, I see what it's doing. Okay, I have an external screen on that I think I'm going to pull out, and then that'll probably do it. So let's see if that helps.
You're on full screen now.
Can you see my slides? Is that correct?
I cannot see your slides.
How about that?
Yes, voice, speech, and communication, the impact of Parkinson's.
Very good. Okay, yeah, I think having that second screen up there, I keep a TV up there, and I'll need it later on when I'm doing the actual exercise. So, okay, thank you, folks, for your patience. I'm John Dean, and I am a speech language pathologist, and I'm going to talk about 3 different topics today as we go through here. I'm going to give you an overview of communication issues in Parkinson's, and I'm going to take kind of an off the beaten path version of that, because I think many of you may have seen some of this information before, so I'll talk about it from a slightly different perspective. And then I'll get into treatment approaches to addressing communication issue in Parkinson's. And then finally, I'll talk about the series. I'm really looking forward to it. We've been at the foundation a couple times. My wife and I are both Parkinson's specialists. She's a physiotherapist, and we've done some trainings and we've done some programs online, and it's been a lot of fun. So I'll talk about the series that's coming up. It's a 10-week program that's going to include an exercise that has breath and voice and some cognitive components. So I'm not going to get into the kind of scientific part of Parkinson's is caused by a lack of dopaminergic neurons. I'm not going to get into that kind of stuff. And I'm just going to kind of keep it very low level and just say, whatever you can see, whatever is visible externally, whether that's the rigidity, the muscle stiffness, or maybe it's the slowness of movement, or in some cases the tremor, although not everyone with Parkinson's has tremor. Whatever is happening externally that can be observed is also happening internally. And that's important because that has a lot of downstream effects on communication. And so, you know, if you start looking at this graphic's awfully busy, but if you start looking at the different places where speech occurs, you have, you know, the lips and the teeth and the mouth. And so if you have rigidity there, that's going to influence how well something travels. And if you have a problem at the laryngeal level, which is where the vocal folds are, the voice box, again, that's probably going to result in the things not moving closely enough together. You have a quieter voice, and then maybe you don't have enough breath support, and then you run into that kind of problem. And then you run into all these other issues on the other side with pitch and volume and the way that maybe you add some pitch changes that could improve your communication ability. You know, we ask questions, and if you put a raising intonation in there, if I go, this is going to be a question, all of a sudden you understand that that has a different connotation than just saying, is this going to be a question? Is there going to be a test? Is this on the test? Like if you say it that way, you can't understand it. And then it has a lot of other downstream issues. And that's important because I think that sometimes we separate things in boxes. We say, you know, this is a motor symptom, this is a movement disorder, Parkinson's is a movement disorder, and really everything's along the continuum. And something that's affecting the physical aspect of Parkinson's could end up having some real influences on the communication. So this is a terrible picture. For many years, there were advocates who were actually lobbying Google to say, don't make this the first picture that shows up with Parkinson's, because it's a terrible image, and it is, but it serves my purpose today. So that's why I'm bringing it out from the dustbin, even though it's out of date. It's not what I see when I see people living with Parkinson's. Because if you look at this gentleman, he has a very forward-leaning posture. And the first thing that happens when you have that is you all of a sudden lose a very important source of nonverbal communication. So your eye contact is impaired because maybe you're leaning forward and now you have to bring your head up, or you have to move your whole body up if you can, so that you can make eye contact. And eye contact is not just important for, you know, turn taking or letting someone know that you're attending, but we also communicate a lot visually. So if you have quiet speech, that's one thing, but if you had quiet speech and you can't see the lips moving, that actually impairs communication quite a bit. It makes it much harder to understand. And then obviously, if you're in that forward-leaning position and you're talking, you're now aiming your speech signal down at someone's sternum or in their belly instead of up to their ears where they can hear you better. So already this is one aspect where physical components influence communication, but then you have all the other parts of it. And I said before, if it's happening externally, it's also happening internally. So my tongue doesn't come out all the way and touch the back of my front teeth when I make a T sound. It's going to sound different. It's going to have more air and it's going to have more noise. It's going to sound like and you're going to have what we call frication. And that makes it much less intelligible. Part of it is that white noise becomes unintelligible, but also it means it's not as loud. And along the lines of it not being loud enough, you run into the same situation with vocal folds. And vocal folds is what all the speech therapists will call the voice box. But basically you have two pieces of skin and they come together and you push air through them and they vibrate, and that makes the sound that we turn into speech. But if they're not coming together all the way, then they're going to have a lot of air leakage, a lot of noise, and you're going to be quieter. You know, and then it keeps going on going down, like breath support again. If you can't get a full lung of air, you're not going to have enough power, and it's going to be harder to communicate. So that's why I say there are a lot of things I could say about speech and Parkinson's, but when I when it really comes down to it, a lot of it is just the physical components of things not having as much movement and not having the strength of movement or the closure if you're talking about vocal folds. And that's why I say the analog is of movements is what you see in speech. And again, small steps, the shorter steps that you might take or would be like the quiet voice. And, the slowness in movement might be related to that word finding problem that so many people talk about because you're not pulling it up off the top of your head so quickly. I wasn't really going to get into this, but I have it on this slide, and I'll just say there are some really interesting studies that show that being in this forward position, this position where you're leaning forward like that, sometimes can affect alertness, and that has an influence on cognition too. And so it all ties together. It has to do with some of the neurotransmitters involved. And I think that that's something that's unexplored, but certainly worth keeping track of so that when you are working on exercise, and we'll do some in a little bit, that gets you more upright and communicating more effectively, it has a complete effect, I think, on all those elements, including cognition. So within the scope of my practice as a speech therapist, I kind of look at three primary areas. So, there's the movement related. The motor always means movement, the motor components. And so that's the muscles involved in speech production and swallowing for that matter, and the muscles involved with breath and upright posture. And then you add cognitive components. And some of that is what we call executive function. And executive function means this kind of global awareness and attention so that when you're talking with someone, you're attending to them and you're listening to what they're saying. And hopefully you're not thinking about what cool thing you want to tell them while they're telling you the story. And hopefully you're not getting distracted by something that's happening in the background. And that kind of attention is important. But then there's also the cognition involved with coming up with the right word. One of the hallmarks of Parkinson's is slower movement, and they call that bradykinesia. Brady from the Greek means slow, kinesia is movement, and bradykinesia is slow movement. And it's not always slow movement in Parkinson's. Sometimes it starts off regular and it just gets smaller and slower as it goes along. When your doctor is doing that test, the Unified Parkinson Disease Rating Scale, they're looking to see if it changes. Maybe initially you can do it well. It's the same thing with a lot of things related to speech. Maybe you start off louder because you're paying attention to it, and then it gets smaller and quieter. But specifically with cognition, there's a bit of they took a term of art, they call it Bradyphrenia, which means slow brain. And the idea is that Parkinson's is kind of different from other issues, other neurodegenerative issues, in that everything's pretty much coming along. It just might take longer to get there. And so many people report, like, I got this thing on the tip of my tongue, I can't quite get it, and then a couple minutes later it comes back. That's the kind of cognition I'm talking about. It's not like other things in other issues like Alzheimer's or something, where there's actually like a loss of temporal awareness and they don't remember stuff. It's more like, I can't process this as fast as I should. And that's a problem because we do a lot of things where we're processing multiple streams of information. Dual task. We are walking and we're talking. I'm on the phone and I'm unloading the dishwasher. That kind of stuff happens all the time. And so things that can influence that and make it more difficult will have a real influence on communication and other things. It increases fall risk. Then the last thing, and I'm going to use this a little bit later on in our exercise, but prosody means the song of music of language, the singing song of language. So when we use prosody well, we'll convey meaning by the way we're phrasing something. So if I was going to tell you about 3 things that I love about Cincinnati, okay, it's not the Bengals, actually. I know they're having a great year. I was talking with Casey. I don't really follow sports. I hate to say that, but I do love Cincinnati style chili. I do like the Cincinnati Zoo, and I do love the Cincinnati Reds. Okay, and the fact that I started with one, and then I said the other, and then I said the third one, you knew that I was done. I conveyed that with the prosody and the intonation, and that's valuable. If you're not aware of that, and especially with Parkinson's, you might not notice that until it's starting to disappear. But those are the things that we can do to work on communicating in a way that's more effective. So I've kind of gone off on a rant there a little bit, and I didn't mean to bring up the Reds. I know that We've got some Hatfields and McCoy stuff going on, between our cities. Although your city is very beautiful, I think it's a lovely place to visit. But I do think that sometimes when you work as a speech language pathologist in Parkinson's particular, there's a lot of focus on loud, and it's loud, 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 and loud is really important, and loud always works, and loud has great research, but there's more to it. There's more to that palette, and we'll get into that a little bit. And along those lines, I'm going to be a nerd for a second and just quote a really, really old study. This is kind of a reference study. It's from the Mayo Clinic. We call these the Mayo Clinic guidelines, even though no one uses this exact approach anymore. And what they did back in the day is they gathered data from all kinds of different people who had all kinds of different disorders. So they had people that had ALS, Lou Gehrig's disease. They had people who had strokes. They had people who had Parkinson's. There's a whole range of issues. And they gathered them, made recordings, and at least 30 in each group, and that has to do with the statistics, but they got good information, and then they had 3 expert raters from the Mayo Clinic, from their department, to rate them on 38 dimensions so they could start to stratify them. And so what they did is they went through that with these 32 people. They had these recordings, and they found some stuff that I'm sure is not going to shock anybody. Monopitch, right? Reduced stress. The imprecise consonants that I was talking about. So your lips aren't coming all the way together. Your teeth isn't making it all the way to your tongue, or your tongue isn't making it all the way to your teeth. There's that alveolar ridge in the back. And then there's some stuff that's kind of very specific to a certain kind of problem, like those short rushes of speech. That's associated with something called palalia. Looking at this list here, maybe I should be careful how I do this. Is anyone noticing something that's missing? Anybody notice something that's like, gosh, everyone I know with Parkinson's has a particular problem that's not really well listed on here? Yeah, okay, again, this is easier in a group environment, but I'll cut to the chase. Quiet speech isn't on there. And it's kind of funny because they used a recording, and they were real careful, and they brought the microphone right up to someone's mouth, and they got a really beautiful signal, and therefore they missed that. I mean, they said mono loudness. I don't know if I can get back to that or not. They said mono loudness, but that not quiet speech, and that's funny because I would say that quiet speech is the most common thing I see in Parkinson's. It's a hallmark of Parkinson's. It should be a diagnostic indicator of Parkinson's. If you have had Parkinson's for a little bit of time and you don't have quiet speech, I'm going to start looking a little closer to make sure that you have true idiopathic Parkinson's and not something that's in a different kind of family there or caused by a different issue. There's a lot of Parkinson's caused by drugs with certain kinds of medications and stuff like that. Now, they did get a lot of stuff right, and I think sometimes it's stuff that we don't necessarily as clinicians always focus on enough, but I think it's valuable to look back at that. So the pitch, the change in pitch is really big. The change in word stress is really huge. The consonants I talked about, and the harsh voice. And the harsh voice is interesting because when your vocal folds come together, they make a nice firm seal. Let's see what we got here. Yes, someone asked me about stuttering. I will definitely talk about that. When you get a nice firm seal with your vocal folds and it's nice and tight, then when you push air through it, it makes a really nice clean sound, and you get a ooh, and it sounds like a bow on a string or something like that. But if the vocal folds are a little farther apart and they're not necessarily as tight and as patent, then you're going to get a lot of harshness in that signal. And so I think this is a really good observation, even though they missed the other one here. So just to take this to the next step, I mentioned that I believe that Parkinson's and quiet speech are so closely tied together that I would call it a hallmark. And the one statistic you see all the time, again from a pretty old study, the studies from the 90s, is that 89% of people with Parkinson's experience communication difficulties. And my asterisk is at some point in the diagnosis. So not everyone has it upon diagnosis, but at some point in time, it's going to be an issue. And again, I find it to be a pretty common one. It's a pretty frequent issue. Now, I'll take that a step further and say that people who just got diagnosed, and this is from a group in England on the Oxford cohort, 500 people, 2 years or less, really a little less than 2 years since diagnosis, 40% of those people are reporting some kind of speech issue. And those are people who are self-reporting. And I bet you if I brought them to my clinic, I'd catch a couple more because not everyone manages to hear it themselves. And then this other study below it, in number 2 in the blue block there, they actually captured audio again. I know that's dangerous. And then they identified speech deficits in 78% of people who had untreated Parkinson's. That's called de novo. And de novo means that you can eliminate, that means you're not taking medications. You're not taking your Sinemet or your Rasagiline if you're really early. You're taking no meds, and that reduces a real confounder in that, sometimes you can say, well, maybe the medications are improving something, and that's not possible because these people are untreated. Now, this is a group in Prague, Dr. Roos and his colleagues, and they do a lot of machine learning approaches. So this is a little slightly different approach. It's not necessarily a clinical thing, but I think his approach is right on, and it's kind of the future. But I think his approach is right on, and it's kind of the future. I think it's here someone's iPhone there. Maybe someone's not muted. It's right on. Did someone get that? Did anyone help me get there? Yeah, good. Okay, great. And I see other approaches to that. I'd say machine learning approaches where they're capturing audio and chopping it up in a lot of different ways. That's really coming, and I think it's going to be a diagnostic biomarker. I think you'll see it. Early approach was a guy named Max Little, where he was doing it with a phone or over the telephone, but I see a lot of things happening on iPhones and Androids. So that's interesting. Almost 4 out of 5 people in Dr. Roos's study, it's a small study, identified with a speech issue. I've seen some Israeli research that kind of correlates that. I've seen some other things out there that's like that. And then this one over here in the pink quadrant is really interesting. There was a famous newscaster in Canada who had Parkinson's, and so they had tons of video of this individual. So they went back and they captured older video, and then they went through and chopped it up, and they saw a real indication of changes in speech, this variability in fundamental frequency. Don't worry about what that means, but it's something that if you have trouble with any of the muscles controlling speech, that baseline pitch, the fundamental frequency, is going to have some changes, and it's a key indicator of Parkinson's. And so that 89% is the one that I think you'll see so often, and it's true, it's absolutely correct. But I think that it also, it's helpful to look at some of the people who are looking at it earlier and not just saying over the course of 20 years, 30 years. Many people I see Parkinson are living for 40 years now. I mean, it's amazing what they've been able to do with longevity and quality of life. But I do see it happening quite often early as well. So I'm going to go ahead, I'm going to talk a little about some treatments now. I will not forget to come back to stuttering, but I think I'm going to keep that aside for a minute or two and keep on with the slides, and then we'll get to stuttering. I'll talk about it directly. So the big approaches that you're going to see in Parkinson's are some branded approaches, and then I'll talk a little bit about what I do that's beyond that, although I am trained, I'm fully trained in Lsvt and Speak Out. My wife and I came and did some training for dual task for Parkinson's, and I got to meet a bunch of your speech therapists, from everywhere, from Allegheny Health Network, from UPMT, from Home Health. You got a lot of talented people there, and they all had at least one of these trainings, and most of them had more than one. And I think it's important because if you're a speech language pathologist practicing with people who have Parkinson's, working with this population of people, working in this community, you have to have this training. You can't really wing it. This is the reference, and it's important that when you're trying to find a healthcare provider in your region, wherever you find them, that they have at least one of these trainings, and they should. And you can ask them that, and they'll verify it. And the only reason why I say that, I'll start with Lsvt, but this approach, Lsvt, has been around for about 40 years. It has 4 lines of National Institute of Health funding, NIH funding. They published dozens of articles, and they have some of what the only level 1 evidence. And level 1 evidence in Parkinson's is really hard to do for rehab. You can do it very easily with a medication. It means a study that was randomized and double-blinded controlled study. And the double-blinded is where things run into trouble, because double-blinded means neither the clinician nor the person who's the participant in the study knows if they're getting the treatment. And again, you can do this very easily for a medication, because you can basically take a pill and make it look the same as the pill that's got the active ingredient, and one's got sugar, piece of cake. But if you are doing a treatment for Parkinson's and you're a clinician, you're going to know whether you're giving the right treatment or not. So to get level 1 evidence is very complicated, and it's a big lift, and I applaud them for doing it, and it's why I continue. You have to get recertified every couple of years, and I always do it because they have the best research out there. That having been said, I don't actually do their exact approach every time, and so I don't call what I do Lsvt out of respect for that, because they have a protocol. But I remember when they were doing one of the first level 1 studies back in Colorado, because a lot of these folks are from Colorado, and they had actually trained a bunch of graduate student clinicians. They do a training every January, and they trained them on this exaggerated articulation approach. And that's different than Lsvt loud, which is loud you think loud, and you use a loud voice all the time. And that's what they do to treat Parkinson's, and it works. And so they managed to get a group of clinicians that were experts, but they were naive to this approach. They trained them in this approach, and then they gave them treatment to a number of people with Parkinson's, and they showed that their Lsvt approach was better. That's very complicated. It's very hard to do. So again, I just want to pat them on the back and say, this is the gold standard, and I keep my certification in it, and I keep up with their research because they're always publishing. But they have an upstart in their neighborhood. It's down in Texas, and it's called Speak Out. It's the Parkinson's Voice Project. And I'm also certified in this, and I got trained when they did their initial live training back in maybe 2011, 2012, and then when they put it online, I tested that and trained in that. And it's a great approach. They look somewhat similar. The difference is maybe the amount of intensity as far as the amount of sessions you do in a month. But one thing that Speak Out did that I think is really smart, and it speaks to the fact that there are a bunch of clinicians that have worked with tons of people that have Parkinson's, is they put everything that you do in a nice little workbook. So you get onto my caseload, and I call down to there and I say, hey, I got somebody here, and there's their information, and they are a patient of mine, and I'm certified in Speak Out, and they ship you for free a book that's about this thick, about 1.5 inches thick, and it's got materials for each day. And so you'll come into my clinic, and we'll work on page 1, 2, 3, and 4. Remote control your screen. I don't think someone's requesting remote control the screen, and I don't think I should do that. So I'm going to decline that. If you need something, unmute and tell me why. If you'd like me to turn on transcription, I can do that. And so again, by having those materials there, it makes it very easy for someone to just say, okay, we're going to do page 1 and 2, and then you're going to do 3 by yourself, and I'll see you the next day. We're going to do 4 and 5. It's a smart thing. It doesn't seem like it's that complicated, but it is, because not only did they have to come up with these materials, but they also had to get the nonprofit grant funding to be able to have that resource that they could ship it out, and they've shipped it everywhere. There's a gentleman at the Parkinson's Foundation here in Lisbon who's trained in this, and they have sent books over here, and it's like, that is pretty amazing. So I'm not picking favorites. I'm not playing favorites. They're both important, and when you're finding a speech therapist in your town, you're going to want to have one of these training, and one of them might actually do like this group had something called a Loud Crowd, which is like a carryover group. They might have that. There's also Loud for Life, which is what the Lsvt folks have put together. The only thing I'll say with Speak Out is that I think last time I looked, they might have 7 or 8 articles. They're growing quickly, but they started off as clinicians, and so they won't have quite the body of research, but what they've shown so far is pretty compelling. So I want to be careful not to play favorites. I like them both. I know them both. I think they're really good, and I don't think we'd be here without Lsvt, but I think Speak Out brings really great things to the table. And I'm going to say this one more time. When you find a speech clinician in Pittsburgh that you're going to work with, make sure they have training in one of these approaches. It'll be very helpful. Moving forward, however, There are other approaches, and I implement a lot of these other approaches into the way I treat. So a couple of years ago, well, about a decade ago, I got hired to do a lecture in the Netherlands, and they have an approach called pitch limiting voice therapy. And their belief is by lowering the pitch, it reduces strain. They have some data. It's interesting. It looks an awful lot like Lsvt or Speak Out. And I wouldn't mention it except they have a really cool app that I'm going to talk about in a minute. But so there's something homegrown out there in actually from your neighborhood, from UPMC back in the day. Dr. Catherine Bertolini, a very well-respected vocalist, has an approach called resonant voice therapy. And it's not directly for Parkinson's, but I liberate it very, very often. I use it quite frequently. Actually, some of the stuff in Speak Out looks a little bit like her work. And that's not to say that anyone's stealing any ideas. It's like there's only so many things you can do, and it's the way you apply it. But I remember Dr. Bernley came to Colorado when I was out there, and I got to have a training there, and it was really an eye-opener. And I was like, I can apply this immediately to people with Parkinson's. Vocal function exercises by Dr. Stemple are another one that I use quite frequently. I like some of the ways they do glides, or he does glides. And then there's technologies like the Speech Vibe, where you put a device in your ear and it puts loud noise while you're trying to talk, and it's a reflex. It's called the Lumbar Effect, and it instantly makes you talk louder. And I don't necessarily go to this first, but I've used it effectively for people who have had difficulty using it, getting that speech up in other environments, whether it's cognitive or whether it's some other kind of influence. Okay, good. Okay, someone's making a map of that. Great. One thing I remember working with a television personality, and we used the Speech Vibe very, very effectively. You put it on this side, and we shot him here, and it worked like a dream. So that's a cool product out of Purdue University to Jessica Huber, and that's another thing to add there. But then beyond these kind of things that I think are very specific for Parkinson's, I think most speech therapists know how to work on easy onset, not ramping up your muscular system if you're dealing with a dystonia. And dystonia is a real common issue in Parkinson's that can influence a lot of factors. I was just talking to someone a couple of days ago who has a dystonia that's influencing their ability to breathe, and it makes it really difficult to get enough breath support when the medications are wearing off. The dystonia, the tightness here at the diaphragm is making it difficult. That's called off-period focal dystonia. Let's talk about disfluency now. Disfluency is the clinical term for stuttering. So someone was asking about that specifically. And disfluencies and I'm just going to keep track of this. Okay, someone has a question about singing. We'll get in there. Yeah, someone's asking about singing. I'll talk about it in a hot second, but probably after this. So with disfluencies, stuttering, there's a couple ways they can present, and one of them was back at that Mayo Clinic thing. They have the situation where people have these short rushes of speech and they can't control it, and it's kind of like when you see a very classic like Awakenings kind of video where someone has the really small steps and they get faster and faster and faster and they lose control, and that puts them at risk for fall. That's called festinating gait. There's a festinating speech. That's the palilalia, and that can be kind of a difficult one to treat. You can use like a pacing board where you'll put something down and it'll touch each word as you're saying it. You can use, do I not have to, I do, my wife has a good pen here. I can demonstrate my number one for that. You can also use technology that's kind of like Speech Vibe, where you put the earphones in and it plays your audio back to you slightly delayed. It's called delayed auditory feedback. And that is a technological way, it tricks your system and it will improve that. Speech Easy is probably the one that I'm most familiar with, but there are probably other devices out there. My go-to for palilalia is I take a pen that's the old kind that has a clicker on it, and I'll use that. I'll have it in my fist, and I'll just that's my cue. So I will talk with the clicker, or if I want to go a little faster, I might even go, I can talk a little faster. And for someone without palilalia, not necessarily that valuable, but for someone who has that runaway speech, it's a real key to intelligibility, you know. And I had a CFY a couple of years ago, and it wasn't my CFY, but at a clinic I was at. That's a fellow. We all have to do fellowships at clinics before we can become professionals, work on our own. And he made a great pacing device for this gentleman that it would fit on his wrist, so like a little wristband, and he would use that. So there's a lot of tricks like that. You can do traditional fluency kind of approaches. And it just depends. Sometimes they work, sometimes they don't. It's a difficult thing to address. But one thing with fluency or stuttering is that sometimes it's related to maybe deep brain stimulation, if that's been done, or certain medications. And sometimes it can be valuable to have a conversation with the doctor that's in charge of programming that or prescribing those meds. And there might be some ways to tweak that. This would be another reason why you want to have a good relationship with a speech language pathologist, because they can act as a little bit of a communicator and intermediary, saying, here's what I'm observing in my clinic and at these times, and that might be something that you and the doctor can use to change that. Sometimes I have better results changing the DBS programming than I do with my own treatment, and I hate to say it that way, but it's just sometimes you can't treat everything, you know. And I don't throw it to the doctor and say, well, he's got a solution, you know, he'll change the pills. Sometimes the doctor, she or he, won't be able to do anything about it, but you just kind of roll with what's available and you keep tweaking it. And sometimes something that works today might not work in 6 months, and you just keep at it. That's why it's valuable to work with someone who has expertise with Parkinson's, so that they've seen a bunch of these things and they have a big bag of tricks and they can try it out. If you've done that and you're the person who's dealing with the stuttering issue and you've managed to not find a solution, you've tried it with some different speech therapists, you might see who at the university or somebody nearby that might be a therapist that works with fluency disorders specifically and not Parkinson's, and see if they have any advice or any tricks. Sometimes I go to a friend of mine that I was in my PhD with back in Colorado. He'll handle stuff that I couldn't do. Okay, that was a lot, but I wanted to cover it. That delayed auditory feedback, that masking, that's all part of that same thing. I'm going to talk about intonation and porosity, so I'm going to skip that for now. Someone was asking about singing and public performance, and oh, great. Someone has a great map here of the therapist and the model they use in the locations. That's perfect. That's exactly right. I'll reinforce this again when I talk about my class. My class is not a substitute for finding a clinician in your neighborhood that knows Parkinson's, that knows you, and that you have a long-term relationship with. You're going to need them over time. We're going to do some great stuff. I'm looking forward to it. I'm really, really excited. It's going to be a lot of fun. It'll be a little bit of magic. It's not therapy. You need to find a therapist. Someone's asking about changes in singing. So she had a thyroidectomy and noticed some changes in voice, and then voice was lower, and then she had another thyroidectomy, and then changes diagnosed with Parkinson's, and now no range. Yeah. So there's a loss there. The thyroidectomies, that's for people with a thyroid kind of cancer, that can influence. It depends. The recurrent laryngeal nerve is kind of in that vicinity. It could be a part of that. I would work with a vocalist, a voice specialist, because they might have more of a feel for what that part of it is. You could obviously working on some of the singing approaches, and there are some good choirs out there. I know APTA does one on the East Coast. I know Northwest Parkinson's Foundation does one. I'm dying to do a choir. I think choirs are really valuable. I saw one from Melbourne that's doing an online one called Parkinson. I saw one in Baltimore called the Parkinsonics. That was the best name I've ever heard. So even if you don't have the range that you used to have, it can still be a fun, pleasurable event. And then you might bolster that with some speech therapy. First with a therapist that knows Parkinson's, but then maybe somebody that's got a little more firepower in voice. Although, again, most of those Parkinson's therapists, I've met many of them, they're pretty good. We can handle a lot. That last thing there, the expiratory muscle strength training, that's a particular device. It's a threshold breath trainer. I should have had it. I have it. It's in my closet somewhere there. And you use it to do a focus training to provide resistance. It was out of Florida with Christine Sapienza, Dr. Oken's kind of group there in the University of Florida. Dr. Oken being the medical director for the Parkinson Foundation, the national organization. And it's got good data. I do some things where I try to do some breath training. We do use that device, but I use some other ones as well, or sometimes I hack them together because it's just different tools for different applications. But that's another one that's got some great data. The data initially on that was for swallowing, which is interesting, but now there's some data for speech too. So I'm going to jump over into, I'm going to talk a little about a couple apps, and I'll tell you why. This is related to the class I'm doing, is that we're going to use some of these apps in the session to let you have biofeedback while you're doing the class with me. And David Von Hoffen mentioned this idea, and I'm glad Casey put it back on my radar because I kind of forgot about it. She's like, oh, you're going to do that? And I was like, yes, I am. This is a great idea. David, by the way, I'm sorry you're not here. I heard you were out and about. Just a passionate, I mean, I just love David. He is so knowledgeable. He's so motivated. I feel like I just love the energy, and I feel that every time. I'm really passionate about this community, and then I come over to see David, and I'm like, well, I'm going to step up my game because I can't keep up with him. So
I'm here, John, and the check's in the mail for saying such a nice thing.
Oh yeah, oh, you are there. Okay, David. God, I love David. You really are one of a kind, and your organization is so lucky to have you there. And you're the one who put this idea on my radar because we've been doing a lot of online classes since COVID happened. We got a grant with the European Parkinson's Association, and then we did some work with the Parkinson's Foundation in Western Pennsylvania, and we're doing it with another nonprofit in DC. And the problem with those online classes, we're making some really effective use of the technology, but people can't understand what they're seeing, and I can only tell what I can hear coming through the mic or what I can see them doing with the movements. And so by incorporating a bit of tech like this, I think we'll be able to maybe give you a little more biofeedback. Now, I mentioned that the pitch limiting voice therapy from the Netherlands, interesting. I don't really use it. I understand the science of what they're saying. It's kind of not my thing, but this is a pretty cool app because they're very simple design. The Dutch are very elegant. There's a ball, and when you're loud enough, the ball becomes green, and it becomes bigger if you're louder, and then it goes up and down to whether you're high enough or not in pitch. And I don't really care so much about the pitch, but I got a video right here. I'm gonna play the video. Yeah. It's just a great bit of biofeedback that we can use, and you can use it when we're doing one of these sessions. So there, I'm too quiet. Now I'm loud enough. Now I'm going up higher. Hold on, go higher. Hold on. There. Now I'm up higher like that. And so that's what it's doing. I don't care so much about the up and down, but the red to the green is enough to give you some feedback. And I use it. Sometimes we'll do glides, and I'll use that for the glides, and we'll play with that. But we're going to hack this app if you want to use it. My only complaint about this app is that it was initially funded by the Michael J. Fox Foundation. It was free when I got it. It is no longer free. It's like $10. So some people might not be into that. I understand that. No one's ever going to accuse the Dutch of being bad entrepreneurs, but it's a great app. It has some cool stuff. If you do buy it, if you're going to join our class and you do buy it, there's some internal, what they call in-app purchases where you can get extra data monitoring or whatever. I bought it a couple of years ago, not worth it. So if you pay $10, you'll have it, okay? And if you don't, I have another option. First, I have an option for people who have Android. And this is an SPL, a sound pressure level meter, a decibel meter. And the cool thing is that this was also funded by a grant in a RERC, a Rural Education Resource Center. So it's always going to be free. And I'll play you a video of this. Someone just asked me this, okay? Yeah, very cool. So this is, oh, she's
clicking
talking.
the slider
again
resets the app back to the B.
I didn't mean to hear her. I'm sorry, guys. Well, we're just going to have to listen to her for a second. So
on the home screen, clicking on logs brings up all the use logs for the application.
So my goal with this is really just the ball and whether you're loud enough up and down. And if you want to get really fancy with it, you can also turn it into a B. I think that's kind of cute. They did that mainly because, they wanted to make it applicable for children in school environments to talk about that as well. So this one's available as for free, but it's only for Android. Okay, so that's a bummer, but don't worry. Oh, sorry, because NIOSH has made their own sound level meter only for iPhone, and it's also free. So that's the National Institute of Occupational Safety and Health. And they published a really cool study in 2014 where they went through and surveyed all of the decibel meter apps that were out there, like 200 of them, and wanted to see if any of them were acceptable for use in an environment where they could actually measure sound level. Now they're interested in occupational sound level, like a construction site. And they only found 3 that were able to do that, and they were all iOS, not Android. And they went to one of them and they bought them, and that's what is available to you for free. So again, this will always be free if you don't want to pay your $10 to the Dutch, although they have very elegant design. This NIOSH one is available, the EA Lab one, and again, it's not fancy. I got another one here. It's not pretty, but it'll give you the information, and it's very, very accurate when we calibrate it. We'll talk about how to calibrate them when we get into our clinic or into our sessions, but it's kind of cool. So those are 3 pretty easy options. The Dutch one is available for both types of phone. I noticed that they charge $8.99 in the United States for the iOS and $10.99 for the Android. I don't know why. Who they angered at Android to make them charge you more, but there you go. And then this is a fun one. This is called Blah Blah Blah, and this was kind of like a design hackathon a while back, where they had people make visualizations for different kind of filters, parametric filters, I believe. And so we'll use this too. It's free. It's iOS. I'll be having this on my phone because basically it's kind of like animal shapes so when you talk louder, wah, these are all faces, and then that's one's creepy. I don't think it's that, but the cat one's kind of fun. And the louder you are, the more it makes the sound. And so it's kind of a fun toy. It's a toy. It's not something I would use for science, but it could be fun for motivation. We'll have some fun with it. So, okay. So now I'm glad I asked about questions early on because I knew this would happen. I'm getting close to the end. I did want to talk about the series. I'm going to do a 10-week series that starts in March, and it'll be weekly on Thursday, March 3rd at noon. And we'll basically do a program each week that'll build on itself. And the attendees, I will send out a link and you'll get a video so you can practice each week what we worked on and keep up with it and do some self-study. Again, I'm a speech therapist. I do a lot of dual task kind of work with my wife, who's a brilliant physiotherapist. And as a result, it's not going to be a standard kind of approach. We're going to do some breath work. We're going to do some voice things, obviously. And we're going to do some cognitive stuff. And that's why I'm going to stop sharing, and I'm going to show you one of these, okay? There you go, okay, so that's the host there. So let me change my background for a hot second. Everyone can see my background right now. You can see me. I've been told I look like I'm in Pittsburgh. That's not real, this is all fake. Good, let me switch up the background. And we were talking before about intonation and porosity. And you can use that very effectively to communicate more intelligibly, but it's not necessarily about more volume. I'm taking out of the way of my own slides here. So you emphasize without adding volume, and we do this all the time. We do this when we're trying to correct something or somebody's not hearing some part of it. So we'll do this by adding a pause, and then we might lengthen the word before it. So we'll pause before or after it, and then we'll add a little bit of vowel length, and this will be a way of emphasizing something. So we do it a lot of times when we're trying to let someone know we're saying a word that ends with a sound that doesn't have the voice versus one that does. So like bop, bob, bop, bob. It's really clear which one I'm saying, and I'm not doing a lot more, but bob's a little bit longer, or duck, or doc, dog, right? Kit, kid. The t doesn't have voice, the d does. And by adding a little bit more length to that kid, all of a sudden it becomes pretty clear that I'm saying the word kid. And that's valuable because, again, if you're not aware of that and you're having a communication breakdown, as people sometimes do with Parkinson's, you might be trying to say it with the same level of monoprosody, mono-pitch, mono-loudness, all this stuff that the people at Mayo Clinic figured out in the late 60s. And you're getting frustrated or you're having a hard time communicating. And I would say if you can basically experiment with adding a little bit of pause before and after a word, adding a little bit of length to the vowel sound, you can make it more intelligible. and that's easier. You can also increase the volume, but I say do that carefully, because if you do it wrong, you're going to sound like you're angry. And I'm not here to train you how to be cranky old people, but if you do it right, it can be very fun. So I'm going to show you a little exercise. I used to do a lot of accent modification work. So I used to work with healthcare providers primarily, because I'm a healthcare provider, and they might be from another country, and we'd work on the way that they're communicating with science or working with the patient. And so this came from one of those books. But if you look at this, I'm going to be the guy talking here. I'm going to get up here, I think. I'm going to talk. I'll be the guy in green, and then you guys can say it out loud. And actually, maybe if you want to turn your mics on, that we're going to do this is the way I would do it in class. We'd all have your mics on so I can hear you. So let me just my old man eye so I can actually read it. Okay, so if I say that the part up here and I say, you know, who must fly to Detroit by noon on Thursday? You come back, you'd say, John must
fly to Detroit by noon on Thursday.
Yeah, and that it's John must fly, right? And I'd say, John doesn't have to fly to Detroit. You say, no.
John
must fly to
Detroit
by noon on Thursday.
David's killing this as well, in addition to the other talents. Yeah, very nice idea. Yeah, John must fly. And so by incorporating this, by recruiting this ability, which we already have, we all know how to do this, we just don't think about it sometimes, or we let it go. By using this, then you can communicate, and it's not always about being louder, although louder always works, but it's a way of having another bag of tricks that you can say, okay, I'm going to emphasize the word that you didn't get. Say, no, I want Coke. You know, I mean, if I don't, you heard all this part, you heard all this part, but all I want to let you know is I wanted something to drink, or whatever, used by emphasizing this. So let me switch over to one more, and I'll do it with a video, and then I'll wrap it up here and take a couple more questions before we all disappear. Let's see if I can get to the slide fast enough. I'm sorry, I would normally have this set on a separate place, so I wouldn't be setting up so much. Here we go. So my part is in blue, and it comes up, and then your part comes up in green behind me, okay? So who must fly to Detroit by noon on Thursday? You say,
John must fly to Detroit by noon on Thursday.
and I'll be like, oh, okay. John doesn't have to fly to Detroit by noon on Thursday? And you say, no.
He does have to fly.
Yeah, John
must fly to Detroit by noon on Thursday.
Yeah, little length. John must fly. John must drive to Detroit by noon on Thursday? No.
John must drive to Detroit by noon on Thursday.
John must fly
to Detroit by noon on Thursday.
John must fly to Chicago by noon on Thursday? No. John must fly to
Detroit by noon on Thursday.
I think we're getting it. So John must fly to Detroit by 3 o'clock on Thursday?
John must fly to Detroit by 3 o'clock on Thursday.
By noon on Thursday, yeah. I think I might have said blue and green backwards before. So you guys are the greens, or I'm the blue, I'm the green, you guys are the blue. So John must fly to Detroit by noon today? You say no.
John must fly to Detroit Thursday.
Yeah, someone's really got it on Thursday. And by adding some of the pitch changes that you're adding there, that's very valuable. Thursday, it emphasizes it without necessarily turning it into something too sing-songy. It's just a way of adding some emphasis.
Yeah.
Again, volume always works. Loud definitely works. But this is another part of it. This is a bag of tricks that I would say you can add to it. So I'm going to stop there. As you can tell, I like to talk. Let me ask some questions. Anyone have something that they wanted answered? Anything I didn't get to? I talked a little bit about the stuttering. I talked a little bit about the singing. Any other issues?
What is your background?
Well, I mean, I've been practicing as a speech therapist since 2005. I first worked in what's called trach and vent. I worked at a hospital in Cincinnati. Before that, I was a professional musician, and I had an injury that ended my career. I was a professor of jazz studies at the University of Dayton, and I was teaching all my stuff, and I couldn't play. My hands were messed up, so I started singing everything, and I was singing it terribly because I was a bass player, so I didn't know how to sing. I was a terrible singer, and I hurt my voice And I went to a speech therapist, a very famous man who the vocal function exercises, Joe Stemple. And I was like, oh, what do you do? I was like, I could do your job, except that Joe Stemple's a world-renowned international vocalist, so like I'm an idiot. But he was very inspirational, and so I got into this field, and it's been great. So that's it.
Okay.
Everything you need to know. That's also why I think music is super valuable. Someday I will have a choir. We'll have like a virtual choir all around the world, including Poland. So, yeah.
Okay.
Any other questions?
I have a
I have a question, and it's related, I think, to Parkinson's, but more so to my situation. Is I sound like I slur my words a lot, and I think it might be because I've kind of accumulate saliva in my mouth. Is that a problem with Parkinson's also? I know that a lot of folks have swallowing difficulties.
You know, it's interesting. Drooling, sialorrhea is the medical term, although not for Parkinson's, is common, and they found that it's attentional. It's how much attention you pay to swallowing that saliva and getting rid of it. Actually, that same people in the Netherlands, they did a study where they had a monitor for an entire 24-hour cycle, and there's no more saliva being produced, but it's just not being attended to. Just like sometimes people with Parkinson's don't blink as much as they should, and the facial masking, it's all kind of related to that. That's why it's not really sialorrhea, because sialorrhea is really overproduction. And so I would say if someone's either taking a medication that can increase that, or maybe had a radiation or surgery, sometimes that can actually increase the production. But you're absolutely right, David, in the sense that if you got a bunch of saliva in your mouth and you're trying to manage that while you're trying to talk, it's almost like I'm holding this here, and I'm trying to do something here. Like I'm like someone's trying to catch me here, and I'm going to manage that saliva while I'm trying to talk. It makes it a lot less clear. And again, management style for that, I'd be real hesitant to try to cut the amount of saliva in your mouth, because that has oral periodontal kind of issues. But sometimes you can use medications for that, or you can do some botulinum toxin, not Botox, but something like that, and they can shut it down. But yeah, that's a great observation. It's a matter of managing multiple aspects at once, and then still trying to have clear speech, which is complicated enough.
My husband has Parkinson's, and his hard communication is over phone. Are you suggesting that the exercises you've been giving will help him with the phone, or do you have any other suggestions?
Well, for sure they will, for a couple of reasons. Now, the phone is a very lossy signal, whether it's a cell phone or it's over the lines. They cut a lot of frequencies out in order to what's called vocode it, bring it down so it's easier to transmit. It's more robustly transmitted because it's not so big. It's kind of like an MP3 would be, or something like that. So that's a problem, because you're missing some key frequencies, and that makes it harder. So yes, certainly we would increase volume, and we'll increase some of the sing-songy parts we talked about there. But do I have one? I think I brought it set. I would say the best thing you can do if you're dealing with a phone issue, I don't have the right one here, but having a microphone can be valuable. And what I really need, and they're sitting right on my desk, and I'm not gonna be able to get there because I got too many. I got 15 cameras here. But earbuds that have the little microphone right here on the wire. If you have that, you can use that and bring that closer to you. You put that into your cell phone, right? And you can put that right in front of your mouth, and now you're talking right into your audio signal into the microphone. And if I was having, like, if people couldn't hear me, I'd put these on and I'd move this right in front of my mouth. And again, you're now making it much more intelligible because you're increasing the signal to noise ratio. So that's what I would do. Obviously, you do want to improve your communication so you're better on a phone. But technologically, if you're on a cell phone, even if you're on an iPhone, all your microphones are down here at the bottom, okay? So you could talk like this, and it would be more intelligible. But what would be better is if you had a pair of headphones, and the wire for the headphones where the microphone is, it'll be a little bump. You put that right in front of your mouth, or you can get some AirPods if you want. Although one thing I hate about AirPods is that they're way back here, so the microphone's way back here, so they're kind of noisy sometimes. If you really wanted to go wireless like that, I would get one that had a long microphone piece that put it as close to you, so you'd all look like you were ready to take an order for QVC, but you would be a lot more intelligible. That's a lot of answer, I'm sorry. But yes, phone is a big problem for a lot of people. Although that study where I talked about the frequency variability, that guy did that over a phone. That was Max Lewis. The guy was brilliant. And that was like, David would know. It was like 2007, wasn't it? Or 8, 9. It was a long time ago. And that guy was way ahead of everybody about how to capture the audio and understand how it leads to diagnosis of Parkinson's. It was really brilliant. Another question? No.
It looks like there's one in the chat, John.
Oh, missed it. Okay, I can be speaking normally and all of a sudden I'm not able to speak clearly. I had to clear my throat a few times and I sound foggy. I imagine that's froggy. What's causing that? I think actually kind of what David was talking about. Sometimes you do get a little bit of secretions, as we call that, which is saliva, you know, whatever is in your mouth. And that can get under there. It can escape very gently and quietly past the natural defenses, which is the back of your tongue. Like if this is the tip of your tongue and these are your teeth, the back of your tongue usually kind of keeps up a little bit back here and keeps saliva and food, if you're chewing, from coming down there. And then when it's time to swallow, it relaxes a little bit and the front of your tongue comes up there and everything goes this way. But if it's a little bit relaxed, then the saliva will creep over the back of it and get into your area here and give you a little bit of secretions. And that the secretions will get on top of the vocal folds and give you that froggy sound. It can also be sometimes just kind of like people talk about having like post-nasal drip. It could be related to that. What I would do to treat it, definitely I would talk to a speech language pathologist, because I think there's some interventions you can strengthen that tongue a little bit. You might talk to your doctor, especially if you think it might be allergy related and causing, you know, post-nasal drip or something like that. But I think it's something that I wouldn't ignore, because it's probably a little canary in the coal mine that needs to be addressed, that you can fix now and it'll be easy to fix, or you can wait until you haven't changed the oil in your car for like 9,000 miles and then, you know, bend a valve or something like that. That's not quite a great metaphor, but I like to address these problems early, not wait until they're a big problem that I have to really do some work on. Miss anything else in there? No. Okay. I'm going to look at that map. That map's a great idea. Everybody, again, I really hope you consider joining our class. We're going to have a lot of fun. We're going to use a lot of these virtual backgrounds. We've been doing really cool stuff with that. But I'm going to say this again. If you have Parkinson's, you need to have a long-term relationship with a physical therapist, an occupational therapist, and a speech therapist that knows you, that's in your area, and even better bonus if they're connected with your doctor. But sometimes there's people that have great standalone clinics and they can communicate with any doctor they want. But what we're going to do for 10 weeks starting in March is not going to replace that. You need to have that relationship. So look at that map and find someone.
Hey, thank you so much, John. Thank you everyone for attending. I'll send the recording of this in the follow-up email, including the map and also the registration for the class starting on March 3rd. I hope you all sign up. Is there a limit? Is there a max?
No, I mean, someday we'll get there, but we've had 40 people, 45, 50 people. It's just more cacophony. It's not going to be a problem.
Okay. Well, thank you so much.
Absolutely.
This is
Hey, Dave, I'm really glad you showed up. I knew you were out and about, but of course you did, because you're David.
Yes.
Well, you're my favorite, so I couldn't miss you, even if I had to come in late.
Yeah, right back at you. Now, you guys, again, you folks in the Pittsburgh area, you don't realize what a treasure you have by having someone who's that passionate all the time there, and the rest of your team there. I'm not trying to
yeah, that's out, right. It's the whole group.
Yeah. But you're really good.
Very good.
And we're grateful for you, John, and of course Josepha as well. And thank you. And perhaps we'll see some of you at the Talk for the Doc at 4:45 today. But you know, please sign up for the class if you're interested, and I'll send that follow-up email this afternoon. Everyone,
and remember, folks, it's my favorite 4-letter word: free.
Oh yeah.
There you go.
It's good exercise and no cost.
Yeah.
No, I mean, underwritten by the foundation, so thank you for that too.
You're welcome. Okay, everyone, have a great afternoon. Thank you.
Thank you.
Bye-bye, everybody.